So without further interruptions, I'm very pleased to introduce Rebecca Beck. And Rebecca is based as our new Lymphoma Care Nurse in Sydney, and she'll be covering New South Wales, so she'll be slowly making her way around the state very shortly. And Rebecca has over 20 years of experience in haematology nursing and started a career in Sydney at St George's Hospital before heading overseas and doing multiple different roles over there at University College Hospital, including haematology and bone marrow transplant unit, and the lymphoma research nurse specialist there as well. Since returning in 2010, Becca's worked as a clinical nurse consultant in a role of haematology clinical research. She was a nurse consultant in that, at the Royal Prince Alfred Hospital in Sydney. And most recently, before coming to working in our team, she was working as a nurse educator with one of the pharmaceutical companies. So we are very pleased to have Beck on our team, and welcome, Beck.
Thank you, Donna, for your kind introduction. I am just going to share my screen here. Sorry, bear with me. I hope that you can all see that. So today, as Donna mentioned, I'm going to be talking about monoclonal antibodies. Oh,
sorry, I forgot to put myself on silent. Just before I get headed off, I just forgot to mention, if you have any questions, at the bottom is a Q&A tab, so please type your questions in there and we'll answer those at the end of the session. Thank you. Sorry, Beck, for interrupting.
That's okay, feel free. So yeah, I'll be talking about monoclonal antibodies, and with a focus on two of the more commonly prescribed antibodies, Rituximab and Obinutuzumab. As Donna mentioned about the Q&A button down the bottom of your screen, please do type in any questions that you have, and I've got some colleagues in the background who might jump in and answer those live, but otherwise we will come back and address those at the end of the session. Before I move on, I have a confession to make, and it's the first time I've ever done a presentation using this technology, so please do keep your fingers crossed that technology doesn't fail me, or more likely that I don't fail the technology. So here we go. What are monoclonal antibodies? Well, the definition of monoclonal antibodies is that they're a group of therapies that have been specially engineered in a laboratory to target antigens on the cancer cells. And in doing so, they engage the body's immune system to recognize and respond to these cancerous cells, and they also help the cell destroy itself. But what does that actually mean? So what I hope to do today is to give you some background information, which will help that definition make a little bit more sense. And the way I thought we could do that is to have a very quick refresh on what lymphoma is. We'll take a look at the immune system and how it works to protect us. We'll also look at how monoclonal antibodies work. And lastly, we'll take a bit more of an in-depth look at Rituximab and Obinutuzumab. So what is lymphoma? Well, it's a cancer of the lymphatic system, and it affects our B cells and our T cells, or lymphocytes. And what happens, for reasons that aren't fully understood, is that lymphocytes gain DNA mutations, and this causes them to grow uncontrollably and stops them from dying off when they should. And that can lead to many problems, including a swelling of the lymph nodes. It can cause your spleen to be large. It can affect your bone marrow and your blood production. And it can also affect your immune system and weaken your immune system. And a reminder as well that lymphoma isn't one type of cancer, it's actually a group of cancers. And currently there are around 80 different subtypes of cancer that have been recognised. So today we're going to focus, the two treatments that we'll be focusing on are for people who have B-cell malignancies or a B-cell lymphoma, and that accounts for around 80% of all non-Hodgkin lymphomas. So what is your immune system? Well, it's really designed to protect you. And there are many different tissues and cells that all work together and have different roles to play in order to do this. And it's a very complex system as well. So organs and tissues and cells include your skin, your lymph nodes and the associated vessels and lymphatics, your immune cells, and also your bone marrow. And it's made up of two different components, if you like. So firstly, your innate immune system or your non-specific immune system. And that includes things like your skin, your gut acids, your mucous membranes, and cells such as phagocytes, which they're generally your first line of defense. They mount a response quite quickly to protect you. You then have your adaptive or your specific immune system, and that is a little bit slower to mount a response because it's actually targeting something quite specific. And that's where your B cells fall. They make up part of your adaptive or specific immune system. So how do B cells work? Well, down the bottom in the middle of your screen, you'll see that hairy, nasty looking thing, which is meant to represent a bacteria, for example. And on the surface of that bacteria are proteins called antigens. Up in the left-hand corner of your screen, you have a B cell, and what B cells do is produce antibodies. Now, antibodies, if you want to imagine them like a Y-type structure, the V part of the Y is targeting those antigens that are present on the surface of that bacteria. And if you think about it a bit like a piece of a puzzle, so it will seek it out, it will travel to it, and it will lock onto it. Now, once it locks onto it, it actually engages your body's immune system to come in and kill off that bacteria. Now, B cells don't just produce one kind of antibody, they produce many, many different kinds of antibodies, and that's called a polyclonal reaction. So many different types of antibodies are produced to seek things out that shouldn't be there, lock onto them, kill them, and engage your immune system to come in and kill that off before it causes you problems. So how do monoclonal antibodies work? Well, a process which definitely exceeds the capacity of my understanding occurs in the laboratory to develop antibodies that are all the same, so they're monoclonal. And they're developed to recognise specific antigens or proteins on the surface of cells. So it might be on the surface of a cancer cell, it might be on the surface, in the case of lymphoma, of a B cell. And the monoclonal antibody, when it's injected into the person, it travels to its target, it locks on, and then it activates the body's immune system in the same way that our body's own B cells do. So monoclonal antibodies really have been a game changer for not just people with lymphoma, but also across many other types of cancer or many other types of disorders. So much so that these three gentlemen here were awarded a Nobel Prize for their discovery of how to produce these monoclonal antibodies. So it's a very significant event that's occurred here. So how do monoclonal antibodies work? Let's take a look at that paragraph that I gave you earlier, and hopefully you understand that definition a little bit more. So monoclonal, one type of antibody, generally produced by our B cells, but in this case have been made in a laboratory to target antigens, which are proteins simply on the surface of cancer cells and on many other cells. And in doing this, they engage your own immune system, so those specific immune cells, to come in and destroy, to destroy that cell, but it also helps the cell to destroy itself. Now let's take a closer look at rituximab and what is it basically. So rituximab is also known as Mabthera, and I might interchange those two, but I'll try and stick to rituximab. It's a monoclonal antibody. So it's been engineered in a laboratory. It targets on the surface of our B cells an antigen called the CD20 antigen. And in doing that, it initiates a chain of events that result in the death of that cell. So it does that through three different ways. So direct cell kill, which is basically when that antibody locks on to the antigen, just that mere act of it doing that is enough to kill the cell. Complement-dependent cell death, that's where complement proteins are engaged and they come in and they punch lots of holes in the B cell and it dies off. And then something called antibody-dependent cellular cytotoxicity, which is a real mouthful, but basically that's where our immune system is coming in and killing off that B cell. It targets CD20 positive B cells, and it's used widely across B cell lymphomas. Just for example, diffuse large B cell lymphoma, which is one of the more aggressive, common aggressive lymphomas. Burkitt lymphoma, follicular lymphoma, which is one of the more common indolent lymphomas, and CLL, but it is widely used across B cell lymphomas. In fact, I wouldn't mind betting that some of you watching this today have either received rituximab or your loved one has. In the setting of diffuse large B cell, it can be given frontline, so that means if you've had your first diagnosis and you haven't had any treatment before, and that's generally in combination with chemotherapy. It can also be given in relapse disease as well, in combination with chemo. And in follicular lymphoma, just to take two examples, it can be given in frontline disease, so the first time you're receiving chemo and therapy. It can also be given in relapsed and refractory disease in combination with chemotherapies such as CVP or bendamustine. And it can also be given for follicular lymphoma patients in maintenance therapy. So what that means is you receive rituximab alone for a period of 2 years every 2 months. Is it effective? Well, the short answer again is yes, and certainly it was a real breakthrough treatment for patients with B cell malignancies. If we just take one example here of a study which is looking at diffuse large B cell lymphoma patients who received CHOP as opposed to patients who received rituximab and CHOP, their outcomes were significantly better than patients who received CHOP alone. And again, as I've mentioned a couple of times now, it really has been a breakthrough treatment. How is it given? It's given as an intravenous, so that means in your vein infusion, and it's generally given for the first time quite slowly, and you'll be closely monitored. And that's because of something called infusion-related reactions. And we will cover those off in a few slides' time. But the risk of infusion-related reactions is generally the highest in the first time you have it. You'll be given medications to try and reduce those from happening or reduce the severity of them. But on the whole, they're very well managed just by slowing down the infusion or temporarily stopping. So your first infusion, really, you could probably set aside the bulk of the day, and then your subsequent infusions are given more quickly, generally over around an hour and a half. You can also receive rituximab by subcutaneous injection. So that means an injection given into the fatty tissue under your skin. That can only be given once you've received at least one intravenous infusion, and that's just so we can monitor any reactions and deal with those. You'll also be given pre-medications, and it's given quite slowly over about 5 minutes, and you'll need to remain in the clinic for about 15 minutes just to be observed. So you can see there's a significant time saving there. So side effects of rituximab, I'd like you just to hold that thought because we're going to come back to that because many of the side effects are similar between rituximab and obinutuzumab. So what is obinutuzumab? It's also known as Gazyva. So if you're receiving it, you might hear the nurses or the doctors refer to it as G plus your chemotherapy. It's a monoclonal antibody and it targets CD20 positive B cells. It too initiates a chain of events that result in the death of the B cell, including direct cell kill, complement-dependent cell death, and antibody-dependent cellular cytotoxicity. That phrase doesn't get any easier the more you say it. Now, you might be thinking, well, that sounds a bit like rituximab, and you're right. It does sound a bit like rituximab. It targets the same antigen and it implements the same processes to kill that B cell off. However, there are a few differences. So obinutuzumab is the first of its kind. It's a glyco-engineered type 2 monoclonal antibody. So rituximab is a type 1 monoclonal antibody. And what that means, again, surpasses my brain capacity, but Glycoengineering is where in the laboratory the sugars on the antibody have been modified, and that makes them super attractive to those immune cells that are going to come in and kill off the B cell. Type 2 monoclonal antibodies also induce a much higher level of direct cell kill. So that's where the mere act of the antibody seeking out and attaching to that antigen is enough to kill off the B cell. So that occurs more in type 2 antibodies than it does in type 1. When do we use it? Well, it's given in combination with chlorambucil for previously untreated patients with CLL. It's also given in combination with chemotherapy in patients diagnosed with advanced stage follicular lymphoma. And it's also given in combination with bendamustine for those patients who have refractory follicular lymphoma. And again, it's also indicated for maintenance therapy for patients who have follicular lymphoma. So that once every 2 months for a period of 2 years. Is it effective? And like I spoke to you about rituximab, there have been many clinical trials that have occurred. And if we just take, for example, in the setting of CLL, the addition of obinutuzumab to chlorambucil resulted in significant improvement in clinical outcomes for CLL patients. And one example of that is the median progression-free survival. So that just means the average survival time before progression was 11.1 months in a group that just received chlorambucil, as opposed to 31.1 months in the group that received obinutuzumab. So again, another very significant improvement there. How's it given? It's given as an IV infusion or an intravenous infusion, and again, quite slowly initially. In fact, with obinutuzumab, you'll receive your first dose over 2 days, and that's just to monitor you again for infusion reactions. You'll have medications to try and reduce the severity of those. And again, they're generally managed by slowing or temporarily stopping the infusion, with subsequent infusions given more quickly. So just to touch now on infusion-related reactions. So on the whole, monoclonal antibodies, and rituximab and obinutuzumab specifically, are very well tolerated. They don't present with the same sort of side effects that you might think of occurring for people that are having traditional chemotherapy. One of the main issues with them are infusion-related reactions, and these are defined as any event that occurs during or within 24 hours of receiving rituximab or obinutuzumab. And what can often happen, or what is often seen associated with infusion reactions, are things like nausea, chills, fevers and shakes. There may be a drop in blood pressure, headaches, some chest discomfort, throat irritation, but essentially anything that happens whilst you're receiving your infusion or within 24 hours could be a sign of an infusion-related reaction. And the way they're managed really depends on what's happening and how severe it is. So, for example, as I've mentioned now a couple of times, on the whole, just stopping the infusion and giving you a little bit of time is generally enough to manage what's going on. But sometimes you might need some additional medication to settle those reactions down. You might need some additional intravenous fluids. It really depends on what's happening. But what I do want to say is that rituximab has been given for a very, very long time now, and obinutuzumab has also been given for quite some time. So the nurses that are treating you are very used to not only managing these infusion reactions, but recognizing them as well. So please just rest assured that you're in very safe hands. But what you can do to help us, or help the nurses that are looking after you, is if you are feeling unwell when you're having your infusion, is to just shout out and let them know. So some side effects that have been reported for patients having both rituximab and obinutuzumab are listed here. And really, I probably could have filled a number of slides with reported side effects. And what I think is important to remember is that these are just things that may happen. They don't necessarily happen to anyone, and you may not experience any of these side effects. As I mentioned before, on the whole, rituximab and obinutuzumab are really well tolerated. What I'd like to sort of leave you with though is to make sure that you let your nursing team or your doctor know about anything that you might be experiencing so that we can really help you through that, because you shouldn't feel that you have to just endure things, because on the whole there might be something we can give you to help or help you, support you through what's happening. You may also experience side effects which aren't related to the monoclonal antibody at all, and they might be related to your chemo, and some common ones that are reported are nausea, low blood counts and fatigue. And again, just to make sure you speak to your team about those. You shouldn't have to be putting up with nausea. There are many different treatments that you can have that can combat that. And certainly fatigue. My colleague in 2 Lunch with Lymphoma sessions time is going to be covering fatigue. It's a really complex issue. It can really affect quality of life, and she's going to be going through some reasons behind it and some management strategies. So please do jump onto that if you think that might be useful to you. What I thought I'd do before I finish up is just to go through some things that we get asked fairly often by patients calling in or on forums, etc., and address those now. So firstly, we do get asked about patients sort of say, oh, I feel like I'm getting the flu. Is that normal? Well, it has been reported, and it is a side effect of monoclonal antibodies. It's very important though that if it's occurring whilst you're having your treatment or within that sort of 24-hour period, that you seek medical attention, because it could be a sign that you're having an infusion reaction. Another question we get asked is, will it affect my blood counts? And again, the short answer is yes, it possibly could affect your blood counts, in addition to potentially the chemotherapy that you might be on affecting your blood counts as well. And one such blood count is your neutrophils. So low neutrophils might lead to neutropenia, and this has been reported in patients having monoclonal antibodies. Again, you'll probably be closely monitored. Your blood counts will be closely monitored, and there are certainly things and supportive medication that you can receive to help with that. And then lastly, or not lastly actually, is fatigue normal? And we've touched on that already, but it has been reported, and it can be an issue, not only just for patients receiving treatment, but for patients who are off treatment and long-term past having treatment. So please do let us know and reach out to your team if you're struggling with fatigue. Can I get the flu injection? I think you need to check this with your doctors, but on the whole, yes, you can. But you do need to speak to your team about it, because if you're currently on treatment, you might need to have your flu injection at a certain time in between your treatment cycles, and you may need to have a couple of them. So please do speak to your hematology nurse or doctor before you go and have your flu injection, but on the whole, yes, you can have it. What about other vaccines? Well, again, really important that you speak to your doctor about it, because you shouldn't be having some types of vaccines, live vaccines. And if you have had a vaccine, please let your team know. Am I more susceptible to infections? Again, this is going to be different for many people, and it depends really on where you are and what you're having for your treatment. But yes, you may be more susceptible to infections. So you need to take all that advice on board that you would have been given by your nurses and doctors around being safe and not getting too close to people who might be unwell, or taking some extra precautions. And I guess particularly at the moment in the current environment, it's a question that comes up quite a bit. And you know, being susceptible to infections might be related to treatment, but also other factors such as your disease, your age, etc. And lastly, why am I having maintenance treatment? Well, there have been studies that have shown in follicular lymphoma that having maintenance treatment of your monoclonal antibody, so Rituximab or Obinutuzumab, has an advantage in delaying progression. So that's the current recommendation, but again, it's very dependent on your individual circumstances. So where can you get some more information if you would like it? So I don't know if you guys are familiar with EviQ, but it's a website that's been developed by the Cancer Institute of New South Wales, and it has some really great information on chemotherapy protocols and chemotherapy. So I'd really recommend you to jump on there if you need information. Also, the company that make Obinutuzumab also have developed a website, a patient support website, where you can get some more information on Obinutuzumab. And definitely last but not least, please do seek us out. So Donna's already been through a lot of this information, but just to reiterate that we are out there and we're really, want to be able to help you through your lymphoma journey or your loved one. So please reach out to us if we can be of any assistance at all. That's our pretty faces. And lastly, but not leastly, just to say thank you to you guys for coming and joining us today. And please, if you have any questions, please feel free.
Wonderful. Thank you, Beck. That was a fantastic overview and some really helpful information patients going through and well explained. Thank you very much. We've got lots of questions. So thank you for everyone to putting your questions in. We'll do our best to answer all of them. So Anonymous, so for CLL type, which antibodies what antibody treatment is more common and well tolerated? So Rituximab versus Obinutuzumab.
Look, to be honest with you, I don't know the stats around, how many CLL patients are getting Rituximab or Obinutuzumab. I don't know, Donna, if you have more information on that, but both are indicated for the use in CLL. Both are reasonably well tolerated. Donna, do you have anything to add to that?
I think sometimes it's still a bit of clinician choice.
Yeah.
And I think it's very back down to the actual individual patient. From some of the reports I've received from clinicians and doctors, is that sometimes Obinutuzumab can be a little bit harsh on the immune system for some people, so it's very dependent on the person. So if they've got a lot of health issues or older patients, they may opt for Rituximab, a different type of chemotherapy like chlorambucil, rather than having heavier chemotherapy plus the Obinutuzumab. So it's just very dependent on your doctor, but as you mentioned through your presentation, Beck, Obinutuzumab and chemo is superior optimum therapy, but it's very dependent.
I think the other thing with the difference between patients who are getting Rituximab compared to Obinutuzumab is Obinutuzumab is indicating patients who aren't eligible for or wouldn't be given a particular type of Rituximab plus chemotherapy regime. So it's not for everybody, which may mean that it might not be suitable across the board, but in terms of how well it's tolerated, etc., I think they're both fairly well tolerated overall.
Exactly. I think it's the experience of the clinician as well.
Yeah.
Yeah, what they prefer to use. So we do list all these on the fact sheets that we do have what the optimum therapies are, and it's a question for your doctor. Yeah. Carol has asked with the weight gain from Obinutuzumab, is it likely to come off again when I finish maintenance therapy? It's a question we receive a bit.
That's a good question, Carol. I don't know the answer to that, I'm afraid. Is there any hard and fast evidence around that, Donna, that you know of?
No, I think it's again very dependent on the person. I think and unfortunately, men and women also have additional issues with hormonal imbalances that that chemotherapy and treatment can cause as well, and that is an additional issue on top of all the steroids and all the treatments and how it mucks around with people's bodies. So unfortunately, there's no crystal ball to whether that will help after treatment.
I think there's another question there about if an infusion reaction happens, how is it treated? So that really depends on what's happening. So what would probably first happen if an infusion reaction were to occur is that the treatment would be stopped, and it would really, the nurses would assess what's going on and how severe it is. If it's not really that severe, so if it's a fairly low grade infusion reaction, they'll probably just give you a little bit of time just to recover. They may not need to give you any additional medication. And then once it's recovered, they'd restart that infusion, but they'd probably start it a little bit slower than when you were having it when the reaction occurred. And then if you were fine, they'd just keep going and increasing the rate little bit by little bit. So yeah, I know that's a bit of a vague answer, but it really depends on what's happening. But on the whole, stopping would be the first thing, assessing what's going on, and then giving you some time to recover from whatever's going on, and then restarting.
Yeah. And I don't think you mentioned in the presentation as well the reason why people react to first line treatment.
Yeah.
A little bit rather than alternate one.
Yeah. Sure. So infusion reactions occur when they occur more frequently in the first instance because there's a greater amount of disease on board. And what's happening in an infusion reaction is that when those B cells, if you like, are being killed off, cytokines are being released, and that's what's driving those symptoms. That's what is causing them to happen. So once you've had your first infusion, it's most likely that the amount of disease that there is on board has decreased. So therefore, it's less likely to occur the next time around. Anything you want to add to that, Donna?
No, that's perfect. Yeah, and I guess with some patients, especially with really high, bulky disease,
yeah,
quite often patients, doctor may give you steroids, for instance, or some chemotherapy prior to giving you monoclonal antibodies, just to try and get your lymphoma levels down a little bit before they then try with monoclonal antibodies too, for that reason. Yeah, cool. Jeff has asked, is bendamustine treatment synonymous with CHOP?
You mean, is that given in conjunction with CHOP?
Better than CHOP?
Say again, sorry.
Is bendamustine treatment synonymous with CHOP?
I'm sorry, Jeff, I don't really understand the question. Donna, do you?
It is recommended over CHOP, and it has a better outcome for patients with follicular and mantle cell lymphoma. So that might be where you're meaning, Jeff. You can maybe send me a message if I haven't answered this question correctly or what you were understanding. So yeah, ultimately the research has shown, I think it was a still study, that does show that bendamustine does have a superior over R-CHOP, bendamustine over R-CHOP. So it's very dependent again on the person. Again, your clinician will select treatment that is best for you, and taking into account your individual situation, your health, your age, things like that, before they would be recommending either benda or CHOP. So,
and is that in what disease, Donna?
Follicular and mantle cell.
Yeah, thank you.
Shirley has asked, I am only a week after having my first treatment of Rituximab and bendamustine. Is the nausea likely to last the entire 4 weeks until my next treatment, or will life feel somewhat normal at some point? Oh, it's a very common question.
Yeah, Shirley, and I'm sorry if you're struggling with nausea, and really, no, it shouldn't be lasting the entire 4 weeks at all. And nausea isn't something that you should be putting up with. There are many, many different kinds of anti-nausea medication that you can have, and if something's not working for you, you can most likely be switched to something that will. So please do reach out again to your team, give them a call, and if you need some assistance around that, please reach out to us, contact them and let them know that you're struggling with nausea, because they would want to switch that around and help you through, because no, you shouldn't be putting up with it, and it certainly shouldn't be lasting the 4 weeks.
Yeah, there's so many more choices, and they order what works for most people, but it doesn't always work for some people. So yeah, let your team know. Good advice there, Beck. Susan has asked, I'm on Obinutuzumab maintenance. I have done 4 rounds so far. Just before round 3, I had a grade 4 late onset neutropenia with 0.02 neutrophils. fixed with filgrastim injections. That's to boost your immune system up. Any ideas of how likely this is to happen again during maintenance?
I don't know how likely it is to happen is my answer to that, I'm afraid. I guess if it's happened once already and they've managed it, it might happen again. But Donna, do you have anything more meaty as a response?
Not meaty as generally if patients are having a certain, what you mentioned in your talk is that we can tell you what side effects some people experience, but unfortunately not everybody has some side effects that affect them more than other people. So if it has happened once before, it could very well happen again.
Yeah.
It's also dependent on whether you may have been fighting off another infection at the same time as well. And if your body is already compromised by having the maintenance therapies, and it's still attacking your good B cells, your immunity and your antibody cells. So if it's attacking those and your body's still trying to recover as well after your initial lot of treatment, and then if you're trying to fight an infection, even if you were feeling well at the time, your body is still trying to get around and doesn't have the full strength that it usually does. It can likely happen again, but it might be because you were fighting another infection in there too. So good luck. Try and just keeping healthy and away from flus and whatnot. It's just a bit hard in the winter, especially in Melbourne. Zana Becken, sorry, I hope I pronounced that right. Thank you. That was very thorough. Thank you for your feedback. Sorry. And Rachel, the last question we have here, if there's no more. I have multiple lymphoma on Rituximab. I have low neutrophils, and what is my increased risk of infection? I think we sort of answered that a minute ago, but did you want to just...
Yeah, Rachel, thanks for your question. I think we've covered this a little bit, but having low neutrophils and also, I guess, having lymphoma itself, and there are other things that might impact on you being more open to developing an infection. So yes, you do have an increased risk of infection, so you need to be quite cautious around that, and take all of those added precautions that are particularly being advised at the moment around social distancing and isolation if necessary, but also just in day-to-day stuff, not taking the COVID stuff into account, just being a little bit more aware of if people around you are unwell. Also in terms of being vigilant if you do develop a temperature or develop any signs of infection, that you do need to get on top of that quickly. So seek medical attention.
Exactly. And COVID aside, these are sort of the precautions you should be using with treatment anyway. Is good advice. And sorry, I did miss a question from Alicia. Sorry, Alicia. Is there a reason some people have maintenance every 2 months and others every 3 months? She's on 3 monthly, which is a question.
No, the recommendation is every 2 months. I have heard that it's been given every 3 months, and I don't really know why that is. I guess it's an individual physician choice and recommendation as per each particular patient.
Yeah, I do know a lot of people have gone through that as well. And I think, again, it's just the clinician. It's also your individual situation. So maybe a doctor felt that you're not needing 2 monthly because your disease is pretty under control, and 3 monthly is enough. So less interruption to your life is probably what they were thinking.
Yeah, that's true.
And is there any food you should avoid while having rituximab maintenance? Example, on RCHOP, not to have grapefruit. So just on rituximab maintenance, I don't know of any.
I don't know of any either. Sorry, not sorry, I suppose. No, I don't know of any specific things that you should avoid whilst on Ritux maintenance.
No, I think it's just a healthy, balanced diet and exercise that just try and keep healthy and well is probably the most thing. Yeah, not eliminating anything particular, but just keeping it healthy. But thank you. There were some fantastic questions there, and thank you all so much for joining us. Thanks, Jeff. I answered your question. Okay, good. I've answered the question. Good. Just a reminder, we're just going to be sending out a quick short evaluation of the the lunch with lymphomas we've done the last couple of weeks. So please, we'd love to hear your feedback and knowing what sort of future topics you'd like to hear as well. So, and if we're on the right track. So thank you all again for joining us. Thank you so much, Beck. That was a wonderful presentation and very well explained.
Thank you.
Getting back to the basics, sometimes it helps for us to understand. So thank you so much. And I'll hope to join you all next week with, me on chemotherapy and what you need to know. So thank you, everybody. Have a good day.